So we'll start with the first participants in the first panel. It covers MPDSR and the in-service work. And the participants, as I call out your name, please come forward and take a seat. So first of all, we shall have representation from the Ministry of Health. Madam Helen Mutsi, you are representing the ministry. Please take the podium. On behalf of the 3 program counties, we have the following representatives. From Uasin Gishu County, the County of Champions, we have Mr. Richard Cheserek, the Director of Administration. Please come over, Mr. Cheserek, and take your seat. For the County of Culture, Vihiga County, we have Madam Veronica Musega, the RH Coordinator. Please take your seat. And for the other project county, Garissa County, of course, long-serving RH Coordinator, Mrs. Fatuma Iman, please take your seat. We also have another implementing partner from the DESIP program, Madam Sylvia Wamuhu, please take your seat on the podium. Now I'd like to hand over to my senior, Dr. Okoro and Madam Wangui, to take over this, to take the panel forward. Thank you. Karibu Wangui and Dan.
Good afternoon. Good afternoon, everyone. I think this is usually the hardest session. We've had 2 days, a lot of information, a lot of discussions, and this panel sits between us and the wonderful Nairobi traffic. So we've got a very powerful panel before us. They're going to energize us with some of those pending, those lingering questions that we've been having. And I think I'll challenge us to be keen on what they say so that we have a very vibrant question and answer session after this. So if you'll allow Dr. Okoro and myself to proceed, I am Dr. Wangui Muthigani. I represent USAID in this forum, and I'll give Dr. Okoro a chance to introduce himself as well.
And I've been introduced. Okoro Dan is my name, from UNFPA, and happy to join you once again this afternoon. I hope you are going to enjoy the session, as Dr. Wangui has already mentioned. So we are transitioning to transition from the national, the counties. And so, Dr. Wangui, what do you have at the national level?
All right. Helen, this is for you. And I think we've seen the tremendous support that the national level has got from FCDO through LSTM. So here, based on your national technical oversight role in maternal and newborn health services, how has this program linked training and practice?
Okay, thank you so much for the question. We've had high impact interventions. For example, the EMOC mentorship, whereby we are looking into having skills labs at all health facilities, performing a skilled birth. And remember, according to our Kenyan health system structure, skill delivery is done from level 2 up to level 6. So, as national, as Ministry of Health, we need to have skills labs at every facility that is doing a skill delivery, and this one is going to improve on the skills, attitude, and knowledge and competencies of the healthcare provider. And also, as also scholar was alluding to, the issues to do with MPDSR and also the CEMDs, those are the tools that evaluate the quality of care in terms of maternal and newborn care. if you look at the MPDSR and CMD report, most of our mothers are dying because of the third delays. And what are the third delays? They come due to the skill of the healthcare provider, lack of supplies and equipment. So the ministry has seen the need for us to be able to improve on the quality of care for this mother and the newborn. We need to equip the healthcare provider with skills and competences. So the MPDSR systems will always be in place so that they are able to evaluate and to monitor how is our performance at the facility level. Which type of, which quality of services are we offering our mothers by looking at MNH, that is maternal newborn health indicators in terms of maternal mortalities, perinatal mortalities, ANC attendance, and other indicators. Thank you.
Thank you, Helen. And that brings me to the counties. And congratulations, Garissa. Congratulations, Vihiga. And congratulations, Uasin Gishu. Great performance and excellent. You got double awards. One was presented somewhere in the morning and another one time ya ugali, which I missed. Thank you so much. And we've had the 3 presentations earlier on, and even over the last 2 days, we've had great performance and great things happening. And as they say sometimes, what is this one thing that you pick, which you can be proud of and say and explain that this has worked well for us at the county level? We have got the pre-service, in-service. Of course, those are probably in the training at the pre-service, but many of your counties also have the level 4, 5 facility, which also have got KMTC around them, and trying to see how do those match with your service delivery. And you also have the MPDSR and MONC mentorship. What is this one thing that you picked, worked well for your county? Just explain to us. I start from, and say the champions. So we start from champions. Yes, Sarah. You have a mic?
I think what has worked quite well for us, and especially Uasin Gishu, is the ongoing or the staff mentorship that began with the program, and the training and the skills the staff received really boosted the services, quality of services at the health facilities. We have proceeded as a county to ensure that equipment is put in place in most of the facilities, and the county has supported. We have had our budgets factored in the annual work plans, our CIDP, and we have had, yes, implementation of the same from level 1 facility, level 2 up to level 5. In fact, currently we have a new partnership with the Israeli government that is going to equip about 25 of our health facilities, the labs. And by equipping the labs, we know diagnosis will be made promptly and mainly from the ANC level and throughout to the 4th ANC, we'll be able to monitor our mother as well. And we have, additionally, we got utility vehicles to support supervision by our program officers to the facilities. At least we have a number of staff that the county is going to employ, and this is going to push much of the services. We have a very good referral system, ambulance referral system, and so that this is going to sort out the issues of delays, especially in referral cases. As a county also, we have, maybe I go to the down there, we have a health bill that is about to be approved by the county assembly, where the FIF money, Facility Improvement Fund, will go back to the facilities at 90%. So all the basic supplies that missed, issues of mentorship, including staff teas, will be very available in Uasin Gishu health facilities in a short while. We also have other expanding services. We'll be expanding theaters and equipping for SIWA level 4, Turbo, and the Capiteldon Health Facility. So we think that moving forward, we'll not be behind or like the 3 years that we were.
Thank you.
Coupled with the support of these partners, we hope that we'll move forward and improve our indicators accordingly. Thank you.
Thank you. Thanks, Raman. That means you're talking about the whole health system. Why even the county and engaging other partners to support the referral mechanism, expanding service access, amongst many others. But otherwise, you picked among mentorship was like the seed, which end up being catalyzed to generate all this support. Thank you so much, Serem. And now, next, to the County of Culture. Yes.
Good afternoon, everyone.
Good afternoon.
Okay, my name is Veronica Musiega. I'm a midwife working for Vihiga County. And what I can say is that apart from the mentorship that Uasin Gishu have mentioned, we have actually done very well in mentorship. And I can say even up to this week we are sitting here, all of my sub-county mentors are actually doing mentorship on newborn resuscitation. So we decided that we will be tackling one particular EMOC function until we are sure that everyone is also almost becoming competent before we shift to another particular function. So apart from mentorship, we have also done very well in MPDSR. And for MPDSR, I can say that LSTM started helping us learn how to sustain ourselves by introducing us to the co-funding mechanism, where we, sometime in around 2018, we had a co-funding MPDSR training together with the LSTM, where Vihiga was catering for the participants, and the LSTM catered for the trainers and maybe the logistics. So from there, all through, we've always had in our annual work plan, MPDSR is part of it, and it is part of the annual work plan, and it is planned for all the way from community, to the facility, to the sub-county and the county. And all the committees have been put in place, and they are all functional. Maybe apart from the community one, they will only meet and when there is a death at community level. However, I know it rarely will occur. But at sub-county facility, we will always meet and on monthly basis, and the reports will be submitted. And this has really helped, and even the actions we are talking about here, the response they are, we really try as much as possible to be able to actually respond to what has been found out to be the gap that actually happened. Even up to the other day, we were even discussing on issues. Sometimes when we realize that actions are not being implemented, sometimes we have to push by force. So when we realized that maybe in our maternity the other day, the last quarter, October, November, December, we had an MO who had serious skills gaps, and he was not very willing to be mentored. So we had even to push up to our leadership level, who are very supportive, and we all had the MO even maybe deployed elsewhere until he's able to learn on issues of maternal health and be competent enough to come and work in our theater and even in our maternity. So we have done very well on MPDSR and really following up on the actions. Then again, as part of the actions on MPDSR, we've really tried to ensure that our skills labs that is at sub-county levels are almost being put into place. And thank God for some of also our partners. They've helped us acquire some of the equipment, like the Mama U, the Mama U, the Mama Bathi, and the neonatally, which are the key components of the skills lab. All our sub-counties have gotten. 2 sub-counties have identified the skills lab and placed the equipment in the same. And even last week when they were doing mentorship, they were actually using the same equipment and also using the skills lab to actually perform the procedures. And we've extended to other facilities just apart from the main facilities at sub-county level. Thank you.
Thank you so much. I can see the good culture of mentorship and also an MPDSR going on very well. And thanks a lot also for introducing yourself as a midwife, and we can see. Vihiga is my neighboring county, and it's neighboring in many ways, and I know it's densely populated, so even by contact, you can just pass the skills. Anyway, on a light note. And thanks a lot to the co-financing from the governor. I think LSTM started winning them. Is it too early? Or you have winned them for a long time? Yes, because for 4 years, 5 years, 2018, or 2019. Okay, yeah, CBC, so you are now getting mature, so it's great. Garissa, Fatma, what's happening that side?
Garissa, good afternoon, everybody.
Good afternoon.
I'm Fatuma Iman. I'm a nurse midwife. First of all, I'm very happy to talk about Garissa today. Once upon a time, there was a time Garissa was not even in the national data. But today, at a blink of an eye, from Nairobi to Garissa, our data is visible. So that's a good milestone for the northern region, especially Garissa again. So Garissa County has an active MPDSR and EMOC training mentorship schedules with support from LSTM. I will never forget LSTM again, because the first time LSTM came to Garissa, when it was starting with the 5 provincial hospitals, Professor Charles is here. I was nominated to go and do a TOT training in Embu, but I couldn't go because my firstborn was doing her class 8 exams. Then I wait, this is TOT, this is my firstborn. Then I said, please, will you consider me another time so that I keep my daughter company? And today I'm proud to say my daughter is a registered nurse. She's a nurse midwife, working in one of the sub-county hospitals in Garissa. So by and large, that is how LSTM is known in my house, leave alone in the county, even my. So we have scheduled mentorship programs for 5 sub-county facilities, the referral hospital and the 4 sub-county hospitals. Those are doing very well. The referral hospital had at least some problem with space, but luckily enough, my team from LSTM have shown in their presentation. The other thing is now, I am proud to say again, we are moving from 5 facilities to 54 facilities for MPDSR and a mentorship of EMOC through the support of an upcoming program with UNFPA. So clap for Mr. Dan Okoro and the UNFPA. I'm getting a new baby to support us. So however, the challenges we have is Garissa is neighboring many counties. We get referrals from Kitui, from Tana River, from Isiolo, from Wajir, and the biggest refugee hospitals, which are 3. So whatsoever we do, the other thing we have is the high staff turnover, which we are trying to handle by making a retention package for our staffs through the dashboard. However, we are somewhere proud to say that we are moving ahead to minimize or reduce maternal mortality and improve maternal health. When it comes to skills lab now, I talked of 5, but we are also having an upcoming central skills lab which will be hub for the northern region, Wajir, Mandera, Garissa, Isiolo, Marsabit, through the support of UNICEF. We have received the equipments. We have identified a resource center, a room which is big, and things are underway. So we can even call people from Nairobi to come to our skills lab to use it as an IGA.
Okay.
We have, I said, of the small hospitals, there's the dedicated rooms, and the mentorship is going on. Even today, I saw a sub-county hospital, they were doing something on removal of placenta. When it comes to the dashboard, as I said, whenever we go for support supervision, we have our diaries and we check how many facilities, how many staffs, 2, how many are trained. So we just keep on balancing who is trained and who is not trained. When it comes to funds now, we cannot all the times depend on partners. The good thing with Garissa now, we have the previous governor. Our first governor is somebody who has passion for maternal and newborn health. And he has promised this financial year, he wants to build a MNH complex facility with theater and everything from MCH to theater and newborn unit, which will now give our staffs at least to work under one roof. Then we have fully implemented the CMED recommendations in the county. The other thing we have is the neighboring counties I've talked about them. We have, except from the county referral hospital, we have 4 peripheral sub-county hospitals, of which 2 of them, the theaters are functional well. We have 2 sub-counties where the theaters are not optimally being utilized, and there's a plan to make them 100% fully operationalized.
Okay, let me put you under pressure.
Yes.
Yes, I know you're used to heat, but
Yeah.
this is now soft heat.
Yeah, so I think
Garissa,
in a nutshell,
yes.
that is what we are doing.
Garissa is according to the 2019 census report, which analyzed the latest maternal mortality ratio, which is acknowledged by the Ministry of Health so far. MMR is the highest. What is it that should be done? We are transitioning.
Yeah.
So how do we transition by pressing that 670 or coming downwards?
We are not
What
at
is this one thing that we
670,
should do?
We are at 631 now.
631?
Yes.
Okay. But it's among, actually
yes,
the leading.
we are among the worst. We were at 644, then we came to 641 now. As I said, the most contributory factors are our referral comes from very severely ill patients come from our neighboring counties. But however, even if they come as a facility, we are supposed to be ready for us to make those patients survive. So the plan I told you is to the building of the one-stop maternal and newborn health complex. Because our maternity has only 4 delivery beds, as I talked to you. That hospital was built, I think Helen has seen, and Charles, 1972. There is no infrastructure improvement which was done. So hopefully when we get this complex and we get enough space for our clients and even our health workers where they can have rest and do the work, I think with support from the new government and the willing partners, we are aiming to reduce half that number from 600 maybe to 300 with the hope of the assistance of Almighty Allah.
Thank you, Fatma.
Thank you so much, and over to you. Oh, go on.
Thank you. Thank you, Fatma.
I'm also proud to say she has passed Garissa County Referral Hospital when she was an intern. She's my new, I'm proud of her. Dr. Wangoi passed Garissa County Referral Hospital
Okay.
when it was a
Yes.
PGH.
And Fatma is like our mother. and we're so proud of the passion that she has for women's health. And I think as we're talking about maternal mortality, family planning is one of the key investments that any country or any society can take to reduce maternal mortality and to overall improve women's health and the economic development of our country. Now with us, we've got Sylvia, who is here representing DESIP. And maybe as we think about what is this DESIP program, she can start us off by giving us an overview of DESIP in Kenya. Thanks.
So thank you very much. As you've heard, my name is Sylvia Wamohu, and I am the DESIP director. She's mentioned about family planning, and DESIP is a family planning program funded by FCDO. Yesterday you heard that FCDO funds the largest family planning program in Kenya. This is it, DESIP, and it means delivering equitable and sustainable increases in family planning in Kenya. We focus on poor rural women, youth and adolescents, and persons with a disability. Indeed, we don't like leaving anyone behind, and there's just a general thinking that persons with disability don't have sexual and reproductive health needs, but they do. So we make sure that we also include them in our program. So DESIP works in 12 counties that used to have, I'm using past tense, because now we have improved with the new KDHS results, low MCPR of less than 45%. But now we have seen, due to our work, other partners in the counties that we work, and of course in conjunction with the Ministry of Health, there has been a lot of improvement, and we're very proud of the work that we have done in the counties. So our focus has been to just ensure that women are aware of family planning. And just talking about the interlinkages, because you mentioned about the interlinkages of family planning and maternal health. And that is why I'm here today. I'm sure, of course, when you have family planning, we'll be focusing on maternal health. I'm very happy to be here today because we know that family planning is critical in reducing high-risk pregnancies and births. Why do I say this? We all know that we have cases of unwanted pregnancies. And when we have such cases, some people opt to take unsafe abortion, and that can lead to death. I wish they had taken a family planning method. We also have early marriages or early pregnancies. And the girls, we know that in Kenya we have teenage pregnancies. Their bodies are not exactly ready to give birth, and they end up getting into complications. So again, if they were aware of family planning, since they're already sexually active, I wish they had taken a family planning method. And of course, birth spacing. In the morning during the session, we heard that in some communities, some people do not want to take cesarean sections because they want to have 15 kids. If they were to space, maybe within the 2 years that is recommended, that would take 30 years to get the children, isn't it? So, of course, we would recommend, part of our work is to tell them, don't get 15, at least get 3 or 5. But you can imagine, if they don't space, that woman will be so frail in terms of nutrition, in terms of health, and even the babies that are unborn and the ones that are born, then they'll also be affected. So you can clearly see how family planning is linked to preventing maternal deaths. It is all about the work that we do under family planning, but of course, integrated with many other things. So getting a little bit into the DESIP work, just to show you how we come in, we start right from the bottom, whereby we go to the community level, then we think about the health facilities, and of course we work with the national and county governments. So it's a bottom up and at the same time top bottom. But very briefly, at the community level, at the beginning of the project, we developed social behavior change communication strategies with each of the counties that we support. We did this because we know all the counties are very different. What works in Homa Bay will not necessarily work in Wajir. And we use this to guide our intervention. We work with demand creation agents to implement those strategies that we came up with. And just to give an example, we really utilize the community-based distribution model, whereby the community-based distribution models go and meet the women in the houses. At the community level is where you meet a pregnant woman who is in their 3rd trimester. And this woman definitely need to take up an FP method after giving birth. Today, postpartum family planning is very important. Before that woman leave the health facility, and we've heard from LSTM that they are really doing a lot to train these healthcare providers to offer high quality services. But can they also offer family planning at the point that they're leaving the health facility? So like when this woman comes to the health facility, then they have also moved to another stage whereby they can accept to take family planning services. So we make your work easier. You have a qualified healthcare provider, and we are giving you a woman who is ready to take up an FP method. Similarly, we have women at the community level who've given birth, but somehow they did not take up a family planning method at the time of birth. So we really talk to them so that they can go and take up the family planning methods. And also, sexually active women who are just confused, they don't want to get another woman, another baby, but at the same time, they don't know about family planning. Very briefly, about what we do at the health facility level, it is all about quality improvement, and this is where we train our healthcare providers on postpartum family planning. We ensure they have the right equipment, and very importantly, that the commodities are available. We also just use the same approach, structured mentorship, so that organically, these skills that we build on our healthcare providers can keep moving from one health provider to another. At the national and county level, it's all about policies, so that we can be standardized in our implementation, so that we can have guidelines and ensure that there's continuity and sustainability in our interventions.
Thank you, Sylvia. And I am really, it's music to our ears when you mention postpartum family planning, because it really gives that 360 care for women. Immediately you get a baby, the baby is alive and well, then you can advocate for PPFP. Or ideally, you should advocate for it at antenatal care clinics. But now that we talk of the wellness of the baby, there are times when we get perinatal mortalities. Veronica, briefly, could you walk us through Vihiga County's experiences with perinatal death surveillance and response? Thanks.
Okay, thank you so much. Okay, on issues of perinatal mortality, so sometimes when we have this perinatal death, many times these mothers will really be devastated, they'll really be down. So we have developed a mechanism where our providers are trained on actually just being able to debrief this particular mother on this actually what went on, so that she's able to understand how it was and be able to allow even just being part of the situation and letting her talk out and verbalize so that she accepts the situation. That is basically the psychological counseling. Then after that, on weekly basis, we will actually carry out the perinatal death audits. So we will have the maternity team, and that is the labor ward team, and also the newborn care team, and identify all the files that the babies that we lost. It could be a stillbirth, that is 28 weeks above, both macerated, and also the freshest bees, and also the early neonatal deaths. Those files are assembled, then the team sits, and we are able to go through, so that we are able to identify which are these areas that could have been improved. Like for the MSBs, maybe this mother came with the no-fetal heart, and you realize that maybe there were ANC profile there was a gap there. Could be she had issues with the not taking IPTP, that is malaria and pregnancy, could have possibly caused the death. Then such issues we actually will respond to the community. Sometimes we have a chair as part of the committee, so that we have that response at community level, so that they are able to ensure that they be default at risk women who have not had IPTP and not sleeping under the net, and be able to actually have the interventions at that level. If it is issues of newborn resuscitation, as I said, maybe that is where the gap was. As I told you, even up to last week, we realized we had lost quite a number of mothers, and from sub-county level, we could see 3 were from the sub-county asphyxia, another 2 from the sub-county asphyxia. So our mentors were now mentoring on newborn resuscitation. And before we came here, we actually called all the mentors and updated their skills on issues of newborn resuscitation before they actually went down to the providers, so that they are actually offering quality mentorship. And thank God for the division. They had actually given us the modules for mentorship on like newborn resuscitation, and we have a checklist. So we use the checklist as somebody is actually performing the procedure, somebody is marking the checklist, and any provider that gets like below 85, then we have to redo it again because maybe the skill has not been acquired. Then the MP, after, when we are doing the MPDSR again, we normally have an HRIO who is seated and taking the notes and actually uploading the same on the system. However, I think they've had issues with the KHIS system because they've always told us we've always uploaded all of them. But you realize that some of them, we can't see them on our end, so we have gaps there, maybe, which we really need to address.
Thank you so much, Veronica. Allow me to hand over to Dan.
All right, now we are grateful to the team that has shared with us their experiences. They are from their practice and the observations. Thank you so much, Sylvia, Fatima, Veronica, Helen, Sarem, for the great and wonderful work. Help me appreciate them. Yeah. I want to show you something. Before I came to Nairobi, you know, there was this where I came from the village where the pyrethrum has not been discovered how it works. So you know how we kill the mosquitoes? Yes. So you see that the mosquito is just moving around, isn't it? So you try to, okay, just do like this, yeah, just do like this, and catch it. All right, confuse the mosquito, confuse the mosquito. Thank you so much. Yes, I came from the plains of Kano. Thank you so much. So we call the next.
All right, so yes, we are almost at the end. We just have a small, a short conversation again on the pre-service training, where we have representation from KMTC. We have Mrs. Catherine Waigwe, Head of Nursing Department at KMTC. Nursing and midwifery. Please come forward. Second, from the University of Nairobi, we have Dr. Kanini Matheka, Head of Midwifery Department. I believe it is School of Nursing and Midwifery. From Moi University, we have Dr. Dina Chelangat, Dean, School of Nursing and Midwifery. Most welcome, take your seat. We will have a brief conversation too. And finally, last but not least, Mr. Ibrahim from the Clinical Officers Council, are you around? If not, so the regulator is missing in action. So I think Dan and Wangui, please take it forward. We have the 3 panelists here with us. And while at it, Mr. Cheserek from Eldoret, please raise your hand. He has misplaced his bag. I think it is the event bag. If somebody sees it, please just pass it over to him. Thank you.
Thank you so much. Once again, we are in phase 2, the last phase, so don't get tired listening to these voices. They may be singing baritone, isn't it? And welcome. It looks like the ladies, the man has this. Where is it? Where is? Oh, Commander, I thought it was there. The COC is not represented, Ibrahim. Okay, we'll proceed with the team here. I believe you will be able to share on the experiences. You've heard what has taken place, what the counties are saying, what the Minister of Health has said, and what LSTM has given us, and whether the Minister in terms of the transition. How will your institutions, the colleges where you are, and other research institutions collaborate in capacity strengthening, providing those opportunities based on this program, which will contribute to improving maternal and newborn health. Maternal and newborn health. So the collaboration that your institutions will have alongside the others' research to improve maternal health. I start with Dr. Dina.
Okay. Good evening. Is it evening or afternoon? I want to say that we are very grateful for LSTM, who brought us in the middle. We got to be involved in what KMTC had been doing in pre-service training. And we are very grateful because I remember, I think I was trained by LSTM in 2013. And the then dean of the school learned that there was a training for midwives. And she said, no, we cannot be left behind. So actually, I got a chance through the Uasin Gishu County portion. We came with the Uasin Gishu County, not because the school had been invited, but I got the opportunity to be trained together with a pediatrician because we felt that we needed to be at par with what is happening in the counties. And I really appreciate of all the trainings that I've ever gone. And as I say, my age is, I'm not young in the profession. A lot of trainings I have gone to seminars and workshops, but none like the one of LSTM because it was hands-on and it is hands-on and it should be hands-on. And so I really appreciate the training. Out of that training, it has been of great help because in the Department of Midwifery and Gender, which is one of the departments at the school, we are 4 departments. I think 50% of us have been trained in LSTM skills, updates, and the head of department is here. He can prove that. But I want to say the students have really benefited a lot through the training that we have received because we have Skills Lab. Since we started a collaboration earlier in 2000 with another team, we were able to get some Skills Lab, but we did not have enough time or a scheduled way. So after the training in LSTM, Dr. Lydia Mwanshia, who is now working in LSTM, really took up immediately and was able to put what needs to be done in the midwifery skills lab. And I want to say those who came for the training last year in February were able to see our midwifery skills lab is fairly, we are not saying we have everything, but we are fairly equipped to be able to prepare the students before they go to the clinical area. Because we believe in evidence-based practice, we are also doing research to be able to inform practice, and we try our best to work with the team from the hospital, and as we have been in our discussions upstairs, we will never, as health training institutions, do the job we ought to do when we are out of hospital. So we have to be in the hospital, we have to partner together so that whatever we are teaching the students from the school and in the skills lab, they get the same in the hospital. And therefore, with us from the Moi University School of Nursing and Midwifery, we are working together with the nurses from MTRH, with other teams of nurses from outside to do research to improve practice. And therefore, I want to say through LSTM and other partners, we are preparing our students better for the practice. And we, as LSTM exits, there is a plan which is an advanced stage to make Moi University part of the centers that will be providing CPD points for midwifery educators every 2 years. And so we look forward to that, because we believe with that we shall continue getting updates. Thank you very much.
Thank you very much. Thank you very much. Thank you very much. And Charles, you can see it. You made it happen in Garissa, and you're making it happen again here, 2013, 2017. And yes, Catherine, I know you cover the whole country, KMTC. When you mention KMTC, it's everywhere. But specifically now, how research collaboration with your institution, and as far as this program is concerned.
Thank you for the question. As you said, KMTC is a big baby that has been born everywhere you walk. We have 51 campuses, and take this from our strategic plan, because it's at that point, we are at that point where we are reviewing our strategic plan. And the strategic direction in terms of KMTC research, collaboration, and consultancy are actually the key that we look at. And for us, that then, when we talk about what has been happening, we have been the biggest beneficiary, obviously, of this collaboration with LSTM, coming from the point of that ADEDAM that we did. And then we were able to bring it up, and now we're able to train. And now we're looking at what we have achieved in a very short while. We've been able to look at, because you have to use what you have, the lessons that you have learned. And of course, when we're talking about curriculum, this curriculum review that we are continuously doing, again, informed by research and audits that are done here and by. And actually, last week we were able to we started the review of the Kenya Registered Nurse Midwife curriculum, which we did our needs assessment, and now we are able to collaborate that. To bring in that and collaborate with our stakeholders who are supporting us in terms of MNH. And the other thing that is very key for us, we are able to put the budgets in place as we're looking at our strategic direction. We are able to fund, and now that we have incorporated EMOC as a requirement, is a module in our curriculum. So it is no longer that we may think about it, now it's mandatory. And therefore the resources to be able to support that have also been put in place. And we have also, as I think somebody alluded earlier, we are required to have 20% in terms of the training as on e-learning. Again, we have resources that have been put up so that we can be able to incorporate this and put it on our platform, so that our students can be able to get it and be able to get the same knowledge all over the 51 campuses. And then the other thing that we look at in KMTC is resource mobilization, whether for research or whether for other activities that we have. And we have developed a team for resource mobilization to be able, one, to look at what are the needs and what are the gaps in our training, so that they can be able to look for resources that can be used to provide that and to cover the gaps. And I also want to talk about when we are training the midwives, it has now become a requirement that when we are doing our case studies, our students are supposed to pick a case and be able to follow through, so that they can be able to use it as a learning tool. And so that, again, we have taken it up and we are making it mandatory that when you do your midwifery care studies, you are able to go out and you're facilitated to get out there and do this care study and come up with results. That's
right.
Part of what we are doing.
Thank you. Thank you so much. Quite great opportunity in strategic plan, establishing the KRNM, and among many others, including resource mobilization for research. So research is at the center at KMTC. Yes, Dr. Kanini, from the university. I don't know whether it still has the D or it's a university, but here you are. Karibu sana. How does research play? What is the place of research as far as this program is concerned in collaboration with University of Nairobi.
Thank you. We are still the University of Nairobi. And regarding collaborations and research, as far as this program is concerned, is that we are really, really grateful as a faculty, as a department, because of what LSTM has done. Because through the collaborations, we've had several faculty trained on EMOC, and also we've had our curriculums updated, especially in the field of midwifery, and we are really grateful for that. Now we intend to continue doing collaborations with other organizations and with other institutions, particularly the training institutions, so that we can ensure that our students continue to have what we call skill-based training, because unless they have those skills, then it means that they cannot be able to perform well out there. And now regarding that, we have to ensure that our faculty are well trained. The faculty that were trained by LSTM, they have, a number of them have gone to other institutions, but we still collaborate with them and we consult with them. And the good thing is that they even mentored others in the institution, and we continue to benefit from that. So going forward, we intend to utilize those skills so that we can ensure that our students are well prepared and ensure that the output is good. Now, regarding collaborations with other institutions, particularly the clinical areas, we intend to continue going forward, getting in touch with the qualified midwives and obstetricians in the clinical areas so that we may have updates on what is happening, and that will ensure that our faculty are updated, and also it will benefit the students. And of course, research being one of the core mandate of the university, particularly even what LSTM has done is we partnered with them in doing some of the researches, and we intend to continue moving forward to do research even with the other partners and other organizations as well.
All right, thank you so much. And maybe one last question from Dr. Wangui.
So thank you so much. I know with lecturers there, if you give them a chance, they'll give you a full hour of their time. So for our final question, I'll ask each one of you to give one takeaway as academic institutions in terms of the learning and the evidence that we've taken from the pre-service component of this program. What would be one key takeaway in as brief? Yeah, thank you.
Now, one takeaway that we will adopt for the University of Nairobi is that we will continue using the updated curriculum on the line of midwifery and reproductive health, because from the look of it and from our experience, it's a good thing and it's benefiting our students and the community at large out there. Thank you.
For us, we learned a lot in terms of improving the confidence level of our lecturers and building their knowledge. And one of the key things that I picked is that mentorship sustains that. So that is what we are going to take away from this. We'll continue to mentor our lecturers.
So the takeaway that we go back home with from here is, from the research that was presented, lecturers are very confident and they are so knowledgeable as far as the theory is concerned, but the practical component of training is limited, and therefore we will put more efforts to ensure that our lecturers do practice the EMOC that we have been trained, so they can be able to impart the same to the students in the skills lab and also in the wards. As I had said earlier, the clinical aspect of training is key. Thank you.
So thank you very much. I think those were very powerful takeaways. Mentorship, increase the confidence of your lecturers. And I mean, when your lecturer knows, then you're confident that our health practitioners will also take on the skills. So I think at this juncture, we need to appreciate our panelists. And because Dan knows so much about how to appreciate people using various components in our environment, I'll hand over the baton to him. And thank you very much.
At this juncture, I will abstain. Isn't it? Let's appreciate our panelists with the Nyayo. We used to have someone called Nyayo. Isn't it? Yeah, so those who have lived those ages can know. Karibu, karibu, karibu. Nabanda kitingiza kidole sasa. Sorry.
Okay, thank you very much. In the same vein, I think we sincerely appreciate Wangoi and Dan for a job well done. So let's also give them a round of applause. So thank you very much. Thank you all for the really good participation, the good engagement, the many discussions, including those who are watching us online. I think it has been very fruitful 2 days. And as they say, whether good or bad, everything has a beginning and an end. So we must come to the conclusion of this conference so that we can take forward the things that we've agreed on, the things we desire to do for our country. So at this point in time, to wrap up and close the session, I would like to welcome our program director, Professor Charles Ame, to do the wrap-up session. Welcome, Professor.
Thank you, colleagues. It has been a very exciting 2 days. I know we're probably 75% population left in the room from where we started, but we make allowance for the VVIPs who could not stay for the 2 days. But this has been a very informative 2 days. You will agree with me. And at this stage, I speak with mixed feelings. I remember the first time I went to Garissa, and I met Fatima, and she showed me around. So from that time to now, she's one of the longest serving RH coordinators. All we have achieved together throughout this program. We started from doing some of the routine things, EMOC training, changing the way EMOC training was done, moving it into pre-service, and looking at various ways to improve the quality of care, but trying to embed a sustainability component. So I feel that as we come to an end of this, to the end of this very exciting program in Kenya, this program, I see it as made in Kenya, owned by Kenyans, and will continue by Kenyans. I think those of us who come and go, we're just passers-by. And I think it's up to you to, carry things going forward. Much has been achieved, lots more to do, but I think we have laid the groundwork to be carried forward by our partners. Our engagement with the counties and with stakeholders over the last 1 year through the KMLs, the knowledge management learning events, co-development of the sustainability plans, we have identified additional areas where you need our support. As LSTM, we are keen to take forward all the learnings. We accept the challenge to focus on difficult areas in the country around maternal and newborn health. and we will engage to ensure that effective innovations are backed by policy at various levels, because this is crucial for sustainability. We welcome you to continue engaging with us. We are pleased to share all our experience, our knowledge, our tools, and we are keen that those of you who continue implementing M&H programs, you do not make the same mistakes we have made. You learn from our experience so that your programs will even be more effective. Our sincere thanks goes to the government of Kenya, the counties for the warm welcome and partnership. Special thanks to our founder, FCDO, the people of the UK, for the opportunity to serve the women and the newborns of Kenya. So what is next for LSTM in Kenya? We're still present in Kenya. We still have programs going on in 3 of the counties we currently work in, really looking at improving the quality of antenatal and postnatal care, including postpartum family planning. We're also involved in several research pieces around antenatal care, really trying to answer the question of how do we achieve these 8 antenatal care contacts in a way that is effective and can really improve the health outcomes. We have developed a pre-service MPDSR curriculum for midwives in collaboration with the Alliance for Improving Midwifery Education, which is a global think tank led by UNFPA Sexual and Reproductive Health branch in New York. Kenya is of great interest to LSTM. We have a team based at Kisumu, led by Professor Faiko and Professor Penny, doing a lot of work in malaria and pregnancy. We have several grants with that team, so we're still here for a long time. Our team in Nairobi continues to work on the grants we have. LSTM as an organization, 125 years anniversary this year, has identified Kenya as one of the 6 hubs, global hubs that we want to really establish and expand. And Kenya is in the first phase of those hubs. Like I mentioned earlier on, LSTM has over 400 alumni in Kenya, and we want to really, bring out our alumni to help us collectively, achieve some of our ambitions in Kenya. The mission of LSTM really is about trying to improve the health of people in disadvantaged populations, and mainly doing this through research and education. And this will continue to be our approach. Our approach to education, is changing. No thanks or thanks to COVID. The way we will have our educational offerings will change. You don't have to come to Liverpool to get an education, a master's or a PhD. You can get it here in Liverpool, in Kenya, to the same quality. So lots of exciting stuff still coming on, so LSTM will still be around. I want to use this opportunity to thank all the moderators and facilitators of all the sessions over the last 2 days for doing a stellar job, so thank you so much. For our team in LSTM Kenya, we're just a small family, and I think you guys do an awesome job. It's been challenging, everybody works so hard, and I think it's just been an incredible 2 days. Near faultless. You all know me how I critique you so much, but I cannot find anything to. Even the temperature in the room is perfect. So I think you've done an outstanding job. So just to conclude, I wish you all a safe journey back to your various homes and your jobs, your families, and we will still be around. And before long, I shall be eating ugali. Somebody has promised me. I have not been offered the right one, so I am having my fingers and toes crossed for that one. But thank you so much. It's been wonderful having all of you, and wish you all the best. Thank you.